Hello dear students, we'll discuss a postoperative status. Just to look into that, quite common entity which we will do. What is this postoperative status? You know that, see that equal flap here, this is a thigh here, stump is here. See that, this is above knee amputation. See that AK amputation, say below knee BK amputation we will tell. Usually lower third like this, sometimes middle third at this level will do, not more proximal to that, because proximal to that is difficult to manage with them. You won't be able to put the prosthesis either here or at this level. This is rather below lower third level if this amputation is done. Remember, flap is equal, that's MCQ question. Whereas below knee is a posterior flap, here it is equal flap. So scar comes in the summit, whereas in the below knee scar comes in the front. At that point you have to remember. So equal flap, anterior posterior, femur stump is required length is 25 centimeter minimum. That again MCQ question, remember, 25 centimeter. Heals faster, easy to do, but prosthesis provision and rehabilitation and cosmesis is difficult here. And sometimes they will have a limb, they need a third support also sometimes, whereas below knee they will have proper prosthesis, they walk without any this one, that movement, leg movements are not altered. We can't know because they walk in and see, then only they will come to know when they remove the prosthesis, this fellow is walking with the prosthesis. Otherwise, exact, absolute normal walk, normal gait they can have in below knee prosthesis. But above knee, little limp is there. Some people, third support like a stick. So there is this one, but he has a good flap, heals well, infection occurring. But when there is a infection, vascular disease, low blood supply at the popliteal level, there is no other alternative, because even if you do below knee, it won't take up. Again, further level, second level surgery is eventually second surgery you have to do upper level. There is a above knee amputation. Such situation straight away you do it and get away with the sepsis and limb which is not functioning, which is ischemic, and send the patient home early, because we have got now very good prosthesis for above knee also. That's a different thing. So types, remember about amputation, types, ideal stump, features of ideal stump is a short note for you. Principles for prosthesis, so sepsis, in the ischemic limb, in atherosclerosis, diabetic foot when you do amputation, vascular surgery, vascular problem when you do amputation. Never put tourniquet. Further ischemia of the flap will occur at level. No tourniquet for amputation when you do vascular disease. Whereas in neoplasia, trauma, when you do amputation, always put prosthesis, always put tourniquet, place tourniquet, but not here. Different levels of amputations, you have to other principles, flap, design flap, maintain blood supply, asepsis, stump bone stump should be obliquely placed, and sharp edge should be removed. Fibula should be proximal than the tibia. Then measurement of stump is important. Scar should heal well, avoid infection, avoid hematoma formation, avoid tension. Muscle should suture to the periosteum of the front anterior part of the periosteum of the bone, and drain should be placed, and compression bandage afterwards. And regular physiotherapy and exercise prevent contracture of the joint, and pull down the nerve and cut so that neuroma will not form and pain won't be there. And give a good analgesia prior to the surgery, few hours before the surgery, so that prevent the phantom limb. So these are the different principles which you have to remember. Different levels of amputation. Race is across the head of the metatarsal. Transmetatarsal, proximal part of the, just above the base of the metatarsal, called Gillies. Then tarsometatarsal is Lisfranc, that's the joint, and midfoot below mid-tarsal joint, navicular or talonavicular, that area. Then proximal to that we will do a pyrogaps, mid-tarsal is chopods, pyrogaps, where calcaneum is retained, part of the calcaneum. Then calcaneum is removed, but heel flap is removed. Lowermost end of the fibula and tibia is cut. That is called classical Symes amputation, around 15 centimeter below the knee joint from the tubercle, that is with the posterior flap, that is a below knee amputation called Burgess amputation. Through the knee joint, that is called transgenial, that is Gitti-Stokes amputation, above knee. Then of course hind quarter. So these are the different levels which you have to remember. Always go through, you can go through my book, detail with illustration diagrams, it is there. Complex hematoma, infection, flap necrosis, stump neuroma, osteomatis of stump, phantom limb, scar problem, contracture, all those things should be prevented. Phantom limb is the, even after amputation, patient feels that limb is there, pain in the limb is there. So thinking that even the above knee amputation done, patient will suddenly, while getting limb is there, she start getting up and walking, then they will fall. Because in the brain, and that wherever the brain distribution is there, the brain distribution area, they think that part is there, part is not removed because of the pain just before surgery, severe pain before the anesthesia. So controlling the pain before surgery may helpful instead of getting the phantom limb, which requires reassurance, constant drug treatment, antidepressant drugs, all those things. So it's a distressing disease, problem, complication after amputation. Not in every patient, at least few patients, they will really psychologically upset because they feel limb still even though there is no limb. And not only that, pain in the limb, same level of pain which they had earlier. So pain is not subsided in the same place, which is not there. So there is the called a phantom limb. So you should know MCQ question it, they should have a clear idea how to prevent it. So that is about above knee amputation. It's a very common question asked, equal flap, length, everything you should know, phantom limb complications. Answer the MCQ. The most important technical consideration while doing below knee amputation is thumb should be long, shunt should be short, long posterior flap, long anterior flap. Put the answer in the comment box. I will get back to you later, students. So another MCQ, most frequent indication for lower limb amputation is arterial ischemic disease, trauma, neoplasia, embolism. Again, give the answer in the comment box. In later period, I will give the right answer. Student, please answer it. So students, I hope you have understood this above knee amputation, detail about it, very, very important, common surgery done as far as amputation is concerned. Interestingly, these amputations are done commonly by general surgeons, rather orthopedicians and or plastic surgeons, and this is commonly done for vascular gangrene and diabetic foot, either below knee and above knee. So the two amputations commonly done by general surgeons world over as such. So I hope you understood this topic properly. Thank you so much. I will do sign off for all recording. Students, so please go through my SRB's clinical methods in surgery, current edition. It gives a video like the examination of the different clinical situations. It gives a detailed examination method including history taking of swelling, ulcer, hernia, inguinal swelling, mass abdomen, breast lump, thyroid, neck swelling, salivary glands, all topics including briefly trauma, how to approach, orthopedic briefly. Then it also includes the instruments, specimens, images, briefly operative surgery, entire thing clinical method with a lot of photos, illustrations, each condition's photos are there, it's very clear. And analysis, history taking, detail, examination, general examination, history taking, history of present illness and past history, current history, treatment history, drug history, local examination, inspection, palpation, percussion, auscultation, clinical diagnosis, differential diagnosis, and briefly in a table form, all differential diagnosis. But it doesn't contain treatment aspect because clinical surgery book only for clinical surgery, analysis and differential diagnosis. So treatment should be checked in detail, principles of treatment should be checked in the manual, my SRB manual of surgery. So this is basically clinical book with the videos of each examination with all illustrations, principles, different methods, different techniques, science. My SRB manual of surgery current edition gives a CBM syllabus, entirely covers all topics, general surgery, endocrine surgery, thyroid, breast, GI surgery, urology, cardiothoracic, neurosurgery, then other topics, arteries, disease, veins, its principles, methods, clinical methods, treatment, complications, approaches, with the quotations in the each page. It covers entire thing, including treatment principles, brief operative procedure also, not in detail. And it also covers briefly instruments, images, anesthesia, briefly oncological aspect, and daycare surgery, audit, surgical audit, metabolic response to surgery, pain management, everything covers as far as required for the CBM syllabus for UGs, PGs and consultant, coming consultant also, with the illustrations, photos, a few video lectures and a lot of MCQs online for each chapter with the QR code. Lot of MCQs for each topic, so each chapter it is there, covers everything for UGs, PGs, CBM, MCQs, NEET exam, whatever required thing. Please go through it, very, very useful book. My operative surgery, extensive voluminous book, 2-volume book, mainly for postgraduates and learning surgeons, all procedures including major surgery, GI surgery, general surgery, thyroid, breast and other things, include briefly gynecology surgeries, with step-by-step illustration photos, more than 10,000 photos and illustrations are, and which covers everything for to learner. You can, before surgery, they can go through my book and have a step-by-step for the all surgeries, whatever common surgeries, major surgeries, it is there. You can always go through that in detail. Explanations are there. My small atlas of tissue approximation with the videos shows clearly with the principles how to suture tissues. Dissection and tissue approximation, the two parts in surgery. Dissection is the principle, essential. After this surgery, you have to approximate tissues, deeper layer, skin, softer tissues, everything, bowel, GI, everything. So this principle of tissue approximation clearly given in this book with the videos of it, including laparoscopic tissue approximation. So you can always purchase that and go through that very useful thing for to develop the skin, which is essential for all surgeons. Students, I also request all of you subscribe my website, both in YouTube, Instagram, and so on. My DigiNow lectures to the JP Publisher covers around 220 lectures in detail as far as CBME syllabus, from general surgery to specialty, urology, clinical examination, cardiothoracic, neurosurgery, all topics, GI, rectum, anal canal, colon, esophagus, liver, pancreas, breast, thyroid, neck, salivary gland, general surgery, artery, vein, everything in detail, all topics, theoretical aspect, surgical principle, operative surgeries, the examination, clinical examination videos also. It covers 220 lectures, cover everything. 1 year purchase you can do. It gives detailed thing about explanations with wherever MCQs are required. You can make use of it and you can learn surgery properly as far as CBM syllabus and academic wise also. It gives lot of information towards the surgical field as such. So students, I hope you have understood this lecture very well, and also you can go through my books, all these books, including DigiNow and lectures. Thank you very much.